funders didn't even 100% understand what a physician does as a general physician. Our description as a general physician wasn't something that they really understood. What is our function in our rooms, for example? What is our function in the hospital setting? And happen to be the president of the International Society of Internal Medicine. Across the world now, we've got 78 countries that's members. We're trying to have a standard of care that physicians across the world, whether you be in a first world setting, third world, whatever, what would be the standard of care as a general physician? Because in many countries, that's exactly the problem. That in some countries, they have these subspecialists. You know, we always joke about a big toe specialist. The point is that what should a general physician, what is the standard of care that a general physician, what is the standard of teaching to make sure that you're actually able to do the work that a general physician needs to do? And this is again a focus to try and ensure that we have these principles of treatment, which applies in all communities and in all socioeconomic groups. It's a disease that you're managing, and you need to do it in a way that's equitable, but also that will help the patient to be well in the future. It needs to avoid complications.
And when you say that the funders, you refer to funders as an amorphous group, I'd like to know what you mean when you say the funders approach you, for example, and inquire why there are so many ECGs that are conducted in your practice.
Yeah.
Who actually is the person who approaches you?
Yeah, this was just a sort of a management person. It's not a doctor. You know, and this particular lady came to my practice. We drew the files. It happened to be Transmed. And she looked at the files to physically see the patient's details. Now again, that is, first of all, there's no privacy for my patient, but they say the funder have the right to do that because they are the funder. And if the patient is a member of that fund, then they have to give permission to do it. So it's a difficult thing. I can't refuse to her to see the files because then they say I'm being obstructive. So, you know, we could show them the ECGs and she was happy with that. But again, it just, to me, illustrated the almost a disconnect to understand what a physician does. Clearly, I will do lots of ECGs. It's part of my work. Almost every single patient will have an ECG. Otherwise, I'm not doing my job properly. But again, the management person at the fund, I don't even know what her description was. She's not a doctor. And that's often our other problem, is that the interpretation of what's happening is not done by a peer. It may be a general practitioner who may also not understand the physician space. But that again is where we can come in, where we could explain it. You know, I don't think that there's can I call it a resistance to understand it, but it's just to get to the point where this can be dealt with in a way that you can actually come to a solution without it being an obstructive situation. It's not, you know, the whole idea is that the system must work again to the benefit of the patient for me.
Dr. Kok, on that point, I think it was the Health Funders Association that made the submission that it was appropriate for a GP to, let's say, engage with a specialist in relation to the type of services that were provided in this audit process. What would your comment on that be?
I think I'm not saying that the GP don't have the ability to evaluate, but at the same time, I do think, for example, if there are clinical issues, that the best solution for me would be that another specialist need to evaluate that. Because I don't think that in some circumstances that a general practitioner would be able to make a clinical judgment on the patient. And this is often a problem where certain investigations or an approach to treatment has to be made on the basis of seeing the patient and making a clinical decision. And
because
this is
we
a
are
problem.
not doctors, can you give us a specific example where clinical expertise would be required?
Like for example, I've got a patient this morning where the patient is actually has CA prostate, and I need a bone scan. And then I'm told he's not registered on an oncology benefit, so they can't do the bone scan. So now you have to phone and explain you need a bone scan. The patient's got a lytic lesion in his vertebra. I need to see if there's other bony lesions so that we can treat him. So you're sitting with a funder making a decision on a funding principle, and I've seen the patient, and so you spend another day in hospital arguing a point.
But in
Does
that
make
instance where
sense?
you're speaking to a GP, I'm trying to understand this point clearly.
That was actually not even a GP, it's just a person at the fund who makes a decision on that patient's investigation.
No, I suppose there are two questions. The one is where it's a non-medically qualified person. So we're not dealing with that scenario, but we're dealing with someone medically qualified. And remembering that the schemes are saying, A, this is impractical because we cannot have experts evaluating these clinical notes. And secondly, they say at any rate, a GP has basic medical training, and they would be able to make sense of these clinical notes. So it's in that context that the question arises.
Yeah. And again, it depends on the circumstance whether that is valid or not. So this is not really from a funding point of view as far as coding and so on go, but for example, chronic medication is one of our favorite situations. There again is a guideline management of a patient. So we have the South African diabetes guidelines. And then the funder, there's a medical advisor at the funder who is a GP, then sits with the funding rules. And no matter that our South African guideline says different, that's the funding rule. And the patient cannot access what they actually should have to prevent complications in the future. So there again, that is a general practitioner making a decision on the funding rule rather than on the clinical management of the patient. I don't know if that answers your question.
Not quite. Let me just maybe give my example and you can comment on that. So if you're accused of fraud, waste and abuse because you've overserviced, and there is a GP at the scheme that is, let's say, doing this analysis, would you be satisfied that the GP is able to do this analysis in relation to a specialist practice?
I think the initial management, the initial evaluation, I'd be happy if they pick up a problem, but then I think it needs to be discussed again at an association level so that one could really interrogate it properly. Because I don't think that with the best will in the world that they really are specialists in all these fields. So they may have a funding principle rather than a clinical management of a patient. And I do think there's a disconnect. So I must say that I think there needs to be a next step. So they may be able to determine that there's an issue, but then we need to evaluate that issue. And I think that's where we're dependent on the data from them. I hope that answers. I think the initial picking up that there's an issue, 100%, but then they need to evaluate it with somebody that works in that area. Whatever the specialist field might be, I think would be appropriate.
There's also another area that has arisen, which is recoupment in relation to whether it's over-service or it's fraudulently claimed. What is your association's experience on the practices followed by schemes to recoup funds from members?
Yeah, so we've had some issues, for example, that doctor that I mentioned, whose payment was summarily suspended. And again, if you look at some of the investigations in that situation, it can take a few months. And especially if it's a fund that represents a big part of that doctor's practice, that could really put them out of business. So I really think that there needs to be a sequence of evaluation before such a drastic measure should be employed. And for me, that would be, again, show the data to the association where there are peers that can evaluate it. They've picked up the issue, no problem. Then see what the circumstances are. What is that doctor's situation? What is their support service? Where are they situated? And are the allegations valid or not? And then what can take the next step? But I think to summarily suspend a person's pay and even sometimes this direct payment to patients, although I understand that it is in the scheme, Medical Schemes Act, that they can do that, is really problematic because I can promise you that the patients see money in their account and they spend it immediately. So the doctor will never recoup that. And to try and get money, that's actually your income from a patient is extremely difficult. So I think that kind of sanction to me is very negative. And I think we could avoid it if we had a better system to the point where we can manage that. If the doctor then completely doesn't comply, there's the HPCSA is available.
Yes.
And although I know their process is slow and it does take time, again, that may be a way to expedite it, is to develop a better system at HPCA level where these doctors are properly sanctioned. And again, it mustn't be a slap on the wrist. We cannot afford fraud in South Africa. We really can't.
Yes.
And I think if one or two people are properly sanctioned, it may give a message that this kind of behavior is not going to be tolerated.
Yes, I suppose there are two types of recoupment. So there is one, the ability of the doctor to recover from the patient who's received direct payment.
Yeah.
Because many patients are going to go to Pick n Pay rather than paying a doctor. But there is another recoupment, which is how a scheme gets its money from a doctor they claim has fraudulently benefited from.
Yes.
And so there, apparently the evidence shows that these schemes will force doctors to sign acknowledgement of debts.
Yeah.
And there is a complaint that that practice of forcing doctors to sign acknowledgement of debts is itself, first, it's rampant, it's racially biased, but it's also illegal. What is your experience on that conduct by schemes recovering funds from doctors?
So I've not had any personal experience where it's happened to our physician members, but just generally speaking, I think you have a huge development to that point. You don't today understand that I've messed up for 3 years. There must be a pattern that you've picked up, and surely you could interact before it gets to the point where that kind of sanction is applied. So to me, to get to that point, unless the doctor absolutely does not cooperate and completely doesn't interact with the scheme, there's a huge path that you could walk before you get there. I mean, you're not, if you don't pay your car at the bank, for example, you don't today not pay and now suddenly they're going to come and take your house. There's a pattern, and there's progress, and there's interaction way before that kind of rule should apply. So to me, it's become a very negative, and if, as I say, I don't have experience of that happening in the Physician Association members, but again, it may be happening to physicians that aren't members. But I think there's there's a lot that can be done to avoid that kind of situation. I don't think that should be necessary, the next step. There's a huge amount that could be done to avoid that from happening. And again, as I say, I think the more recent experience with funders, they've become more, can I call it, aware of issues. They've been able to identify issues better. And that's why I think we've seen this explosion of recouping funds, as you've said. But to me, again, if you've picked up an issue, there must be a way to interact with a doctor before it gets to the point where you have to take such drastic action.
There was a slide that you presented on recovery of monies from doctors by the schemes. Can you go back to that slide, please?
To see if it's to the front. Do apologize, I can't remember where it was. It might be further down. Sorry, I apologize, it might be further down. I'm not sure which one, sorry, I don't think I'm finding it. But I think maybe Healthman and SAPAF would take it further, but can you refer to it again? What was your question?
I wanted to go back to the slide because I thought that I saw on that slide that there were agreements that had been reached between the doctors and the schemes to pay back.
I see which one it was at the bottom, yeah. This one. Yeah. Again, that is data given to me by Healthman, so I wouldn't know the detail of those. And I'm not sure what kind of agreement and the recovery amounts, like you said, that there would even be like an acknowledgement of debt, if you can call it that way. I'm not sure what the detail is there.
But Healthman will be able to assist us.
Yes, and I'm sure they'll give you better detail. Sorry that I don't know if that to hand.
Thank you. Will that be, do you have any more slides, or will that be all?
That's all. Thank you, sir.
All right. I don't think any of my colleagues have further questions. We would like to extend our thanks to your association and for your presentation. You may receive further correspondence from us requesting further information, and you may also be invited again. But for now, thank you very much for your presentation.
Appreciate it. Thank you. Thank you very much.
So we shall adjourn until 2 o'clock. I think that's when the next presentation is.